Hello, esteemed faculty, classmates, and colleagues. My name is Olaiya. I am a women's health nurse practitioner and a DNP candidate, and today I will be presenting to you my scholarly project, which focuses on the management of perinatal depression. I'd like to start by acknowledging my committee members, Dr. Graham, Dr. Snell, and Dr. Pettit. Pregnancy can be a joyful experience, but I think we can agree that this may not be the case for some patients. The reality is that no matter the journey, pregnancy is a life-changing event. Considering all the changes that can occur in a woman's life due to her pregnancy, it is no surprise that it may be associated with stress, disappointment, and even depression. Now, depression is one of the more common mental health illnesses in the United States, and it is often diagnosed in pregnancy. The term perinatal depression is defined by the American College of Obstetricians and Gynecologists as a major or minor mood disorder with symptoms that may affect women during pregnancy or in the first year after delivery. Perinatal depression affects 1 in 7 women in the United States. Risk factors include a pre-existing depressive disorder, family history of depression, low socioeconomic status, relationship conflict, and even social support. Unfortunately, 60% of women who have symptoms do not receive a clinical diagnosis, and only 22% of women with this diagnosis are referred for treatment. Perinatal depression has been shown to lead to negative consequences, including low birth weight, preterm delivery, unsafe parenting practices, and maternal suicide. Women who screen positive for depression may be unwilling to seek care due to stigma or shame. So in addition to obstetric providers, pediatric, family practice, and mental health providers are likely to encounter these patients, and it is valuable for these providers to screen and treat patients appropriately. As an experienced women's health nurse practitioner, it's not uncommon to encounter women who exhibit signs and symptoms of depression. In the setting for this project, the physicians and nurse practitioners use the Patient Health Questionnaire 9 to screen women for depression about 3 times in their pregnancy. This project stems from an identified gap in the care of these patients. The question posed in this quality improvement project is, among physicians and nurse practitioners providing care to obstetric patients, does implementing a practice change for early screening and brief assessment of depressive symptoms using the PHQ-9, as well as providing patient education about perinatal depression at the first prenatal visit, compared to the current practice of waiting until 16 weeks gestation to do so, improve the identification of depressive symptoms, and subsequent referral for and access to psychiatric care in pregnant women. The purpose of this scholarly project is to determine whether the care of pregnant women can be improved with the implementation of a practice change for early screening and consistent assessment of depressive symptoms at the project site. Other goals for this project are to provide consistent education about perinatal depression and improve the referral process for patients who warrant further evaluation by a mental health provider. This project was designed to examine existing practices at the project site, investigate barriers to ensuring treatment of perinatal depression, explore existing resources within the community, and formulate a plan to streamline the care of women diagnosed with perinatal depression. The project is significant to nursing because it showcases the pivotal role nurses play in bridging the gap between evidence-based practice and clinical practice. In addition to lost wages, there are costs incurred from neonatal hospital stays, emergency C-sections, and even not breastfeeding, among others. Untreated perinatal depression is estimated to cost an average of $5,296 per year for each mother-child dyad over 5 years postpartum. Perinatal depression is a public health issue, and it is imperative that healthcare systems and organizations make resources available to ensure access to evidence-based care. This project allows the nurse practitioner to assume a leadership role in establishing a new process for the practice. It adds to the nurse practitioner's expertise and promotes the recognition of the advanced practice nurse as a quality healthcare provider to this patient population. This project was designed to facilitate early identification of patients with perinatal depression and ameliorate the challenges associated with them providing treatment. The patient receives early intervention, which will reduce the risk of complications associated with the diagnosis of perinatal depression. Early intervention ultimately will impact the patient, her newborn, and her family. For the obstetric providers, the project will result in a policy that allows for consistency. A uniform process empowers each provider with knowledge of available resources and to make decisions that are evidence-based regarding the management of their patients. The new process may also increase staff involvement in referrals that may alleviate some of the existing provider frustration. The practice and even the hospital will be able to maintain its reputation as a quality provider of obstetric services, retain current patients due to increased satisfaction, and perhaps see growth in new patients. And lastly, developing a process that connects patients with mental health providers helps foster a sense of community and may help highlight, if not address, disparities that affect the community at large. Using the following databases and criteria for the literature search, I was able to narrow my search results from 2,042 articles to the 14 articles that were ultimately included in the literature review. The three themes recognized among the articles reviewed on this topic were perinatal depression screening practices and recommendations, 2, barriers, screening, diagnosis, and management of perinatal depression, and 3, the need for improved access to perinatal depression care. Several strengths were identified in these studies, including the study designs, use of statistical analysis, and authors' discussion of findings. All of the studies also adhere to ethical standards by seeking IRB approval. Weaknesses include the small sample size of some of the studies and the inadequate discussion on how to address social challenges identified as barriers to care. Limitations discussed in the studies include lack of resources to adequately train staff in one study. Another concern is the generalizability of the findings, since the study settings differ from general population and not all obstetric practices have access to on-site mental health services, which were available to the researchers. The two issues that could have been discussed further: first, it would have been good to see follow-up beyond the perinatal period to determine what outcomes improved with early intervention. And secondly, none of the articles clearly discussed the ideal strategy or frequency for screening for depression. Rather, they focused on identifying false positives and ensuring appropriate follow-up. Further research on these areas would add to the body of evidence. Since this project is looking to change the current practice among the providers, a change theory seemed to be the best fit for a theoretical framework. Hurt-Lewin proposed changes occur in 3 steps: unfreezing, move-in, and then refreezing. The first step requires recognizing the need to change and shaking up the status quo. In the move-in phase, change in thoughts, feelings, or behavior occurs. And finally, in the refreezing stage, there is a need to sustain that change. Changes are reinforced and integrated into the normal way of doing things, and this final stage is necessary to avoid a return to the status quo. This project used a quantitative exploratory design through retrospective chart review for data collection. As with most DNP projects, a convenience sampling was selected. This QI intervention was implemented in an outpatient OB/GYN practice with 3 physicians and 3 nurse practitioners providing care to patients assigned female at birth. The ethnic groups seen at this clinic are approximately 42.5% white or Caucasian, 35% Black or African American, 10% Latina, and 5% Asian. 7.5% of the patients at this clinic identify themselves as other or undeclared. A power analysis was used to determine that the project requires a sample size of 154 participants. And since this is not an experimental project, there was no patient contact. Rather, OB charts were used for data collection. The practice manager at the clinic site provided a list of patients who were seen in the clinic for prenatal care in the 3 months prior to the intervention, and those seen at for an initial prenatal visit during the 3 months after the intervention was placed. The project offers no direct benefits to the patients at the clinic, as this is a retrospective chart review, or was a retrospective chart review, and the project had very minimal risk, specifically a risk of breach of the patient's confidentiality. Efforts to secure data and reduce the risk of a breach included the use of a data collection sheet, removing all patient identifiers, coding abstracted data to represent the ranges of the chosen variables, The data collection sheet was then stored and locked on a password-protected computer, providing 2 levels of security. The charts included in this study had documentation that the patient was at least 18 years old, had a confirmed pregnancy by ultrasound, and was seen in the clinic in the 3 months before the intervention for the pre-intervention group and 3 months after the intervention for the post-intervention data collection timeframe. Charts with documentation that the patient was less than 18 years of age, not pregnant at the time of the depression screen, and not seen at the clinic during the study period were excluded from data collection. Any chart that did not meet these criteria were removed from the data pool. Data about depression scores were collected from the PHQ-9, which is a depression screen that's used at the project site. The PHQ-9 being administered at the first visit is the primary intervention in this project. A data collection sheet was developed for this project to record the minimum necessary data to accomplish the goals of the project without including any patient identifiers. As described earlier, charts were reviewed for data collection. Each chart was assigned a number, and the abstracted data was recorded using a numeric code to represent the ranges of the chosen variables and constitute the minimum necessary data to accomplish the goals of the project. No patient identifiers were included in the data collection process, which stopped when the required 154 charts were reviewed. At the completion of data collection, the written list was returned to the practice manager for appropriate disposal and shredding. This is a sample PHQ-9 for those who are not familiar with this tool. And here is my data collection sheet. These 2 handouts were provided to all patients to facilitate discussions on perinatal depression. Faculty support included my chair or course instructor and the Maryville statistician. At the project site, the chair of obstetrics, social worker, and practice manager have also provided support and guidance for this QI project. Other personnel involved in the completion of this QI project with the staff and providers at the OBGYN clinic. The budget for this project was based on anticipated costs needed to complete the study, a total of $1,787.26. Some of the expenses were covered by the project site. For this project, data was collected from 2 independent samples for analysis, a pre-intervention group and a post-intervention group. Most of the data collected were in a yes/no format, but there were a few responses that were ordinal. Microsoft Excel spreadsheets, SPSS, and another software program called PHStat were used for statistical analysis. Excel easily allowed for frequency and percentages to be calculated, and since a comparison between the rate before and after the intervention was desired, the z-test for the difference of 2 proportions, which is a directional form of the chi-square test, was used. Screening for depression at this practice was already at 94% before the QI initiative. However, only 10% of OB patients were screened at their first prenatal visit prior to the intervention. Women in the pre-intervention group waited an average of 6.3 weeks before their first screen, with most patients being screened for the first time between 4 and 9 weeks after their first prenatal visit. The overall finding of the scholarly project was a statistically significant increase in screening, education, and referral between the pre-intervention group and the post-intervention group. The strengths of this project include adequate sample size, the ethical standards that were followed, and the use of standardized patient education. One of the weaknesses is the project design and the use of a convenient sample, which is considered a weaker model than using an experimental design like a randomized controlled trial. There's also the risk of bias and misinterpretation with QI projects, and lastly, the short time frame for implementation, which may have skewed the findings. Facilitators include the support from staff and providers at the project site. Access to a social worker who was on site and available to meet the patients when needed was also a bonus. The increased awareness about mental health in the United States may have also facilitated patients' awareness and eagerness to discuss perinatal depression. Of note, the ongoing pandemic had caused some difficulty in access to care. Patients experienced delays with scheduling appointments, not just at the project site, but also with other specialties, including mental health providers. Another significant barrier for the project was the use of paper charts for OB patients, which made data abstraction tedious. The findings of this QI project suggest that OB patients are better served by their providers when there is an early assessment for perinatal depression. In addition to eliminating a delay in care that was occurring prior to the intervention, the data suggests that more women discussed what signs and symptoms were associated with perinatal depression and how the condition is treated with their OB provider, which addresses the stigma that often prohibits women from seeking care or seeking help for their depressive symptoms. Like two other QI projects conducted by authors Gillis et al. And Jankowski et al., the benefit of having a standardized process was identified. In addition to utilizing a uniform patient education material, providers were more consistent with reviewing the PHQ-9s with their patients and providing brief assessments of perinatal depression scores. This component was important in differentiating pregnancy-related symptoms from depression. And while providers may not have done this before the intervention, they may not have been consistent about their documentation. So the QI initiative prompted more consistent behavior among the providers. Future research on this area could explore whether the findings of this project continued after a longer period, perhaps a year after implementation. Did we continue to use consistent education and early screening? Expanding this intervention to other OB practices within the hospital to see if they have similar outcomes is another opportunity for future research. And third, it would be curious to study patient outcomes to see if that changed as well. It may be valuable to survey providers to gather information about their attitudes and perspectives on perinatal depression care, and a future project may be designed to follow patients through their pregnancy and observe whether early identification led to decreased depression scores. The project allowed for early intervention and identification for patients who are diagnosed with perinatal depression. The initiative also addressed concerns about variability among the physicians and nurse practitioners in the practice by introducing the use of standardized patient education material and clarifying the expectation of providers' next steps after a patient screens positive for depression. The education session that was offered to the staff and providers prior to the implementation of this project also provided re-education on the administration of the PHQ-9, which was long overdue. And provider discussions, which were valuable because they ensured that women not only felt comfortable discussing their concerns, but that they were supported. And continuing this new process of administering the PHQ-9 early and continue assessments for depression through the rest of the pregnancy and postpartum could help women with depression become more accepting of treatment when it's offered to them. With the reassuring findings of the benefit of early assessment in this location, there's hope that this will be a foundation for the development of a healthcare policy that reflects the best practices identified in the review of literature, as well as the project. The strategies introduced as part of this initiative, such as access to an on-site social worker for care coordination, help improve the quality of care patients receive. This QI project also addresses patient and provider level barriers that were discussed in the literature review by removing the stigma of perinatal depression, navigating limited access to mental health providers, and increasing provider confidence in the management of perinatal depression. So in conclusion, the role of OB providers in the care of pregnant patients goes beyond their physical needs. Ensuring their mental health is being addressed during their OB visits adds to the quality of care that a woman receives. While current guidelines recommend screening for depression at least once in pregnancy, the timing for this has not been clarified. The Scholarly Project developed a process to enhance the management of perinatal depression at the project site. The findings of this project reflect a benefit to screening women at the first prenatal visit, in addition to the existing practice of screening at 16 weeks, 36 weeks, and postpartum. The QI initiative also introduced standardized patient education materials and a much needed on-site resource to streamline the referral process, which was well received by the providers and staff as a tool for reducing practice variability. According to Lewin's change theory, the final step in making change is the refreezing phase, where efforts continue to keep the new normal and avoid a return to the old habits. Because this intervention utilized existing or free resources, the financial impact of this initiative on the practice is negligible, making it more of a sustainable change. It may be necessary to begin the unfreezing process in the future, just to reevaluate the process as new evidence or updated guidelines become available. I want to thank you so much for viewing my presentation. I'm going to have my references on the subsequent slides. Please feel free to contact me with questions or comments. I'm looking forward to hearing from you. Thank you so much.